Good afternoon, everyone, and you're very welcome to this Endo-ERN webinar. I'm Amy Casey. I'm the Communications Manager for Endo-ERN, and I'm so pleased that so many of you have registered for this webinar from Professor Fallhammer from the Karolinska University Hospital. Before we get started, I'd like to highlight some housekeeping items. This webinar is actually being recorded and will be available on Endo-ERN's YouTube channel within 48 hours of this webinar so that you can share it with your teams. If you have questions, thankfully, we will be able to take questions at the end of the presentation. If you would be so kind as to write them in the chat, or if you would like to address the professor directly, you can raise your hand and I will unmute you. But all of that will be at the end of the webinar. And then the last remark I'd like to make is that the professors very kindly shared a handout, and you will find that on your control panel. If you look for handouts, that's actually what it is, and that's what it's called. I'm pleased to say that we have our MTG1 adrenal chair here with us today to introduce the professor and to manage the questions. Our main thematic group 1 is adrenal, and they actually organized this webinar today. So without further ado, I'll hand you over to Svetlana Lychik, who is the chair, pediatric chair. Thank you so much, Svetlana.
Thank you, Amy. So welcome everybody, and I would like to present and welcome to Henrik Fallhammer, first of all, who will give this lecture or webinar for us about non-classic CAH, an underdiagnosed condition. And Henrik received his PhD in endocrinology in 2010 from the Karolinska Institute on the subject congenital adrenal hyperplasia in adults. And Associate Professor Henrik Fallhammer is also a senior consultant in adult endocrinology at the Karolinska University Hospital and a senior researcher, and has been involved in numerous clinical studies concerning patients with CAH throughout the years. You are supervising many different, several students, 7 PhD students at the moment in different topics. Everything, topics regarding CAH, but also other adrenal disorders. And Henrik has also published more than 200 papers, and approximately half of them are about CAH. So welcome, Henrik, and please, you can start your lecture.
Thank you, and thank you for inviting me for this webinar. So I'm going to talk a little bit about non-classic CAH. And the first picture is from my work in Australia, and I used to work as a flying endocrinologist, and then I saw these 2 islands in the Pacific Ocean, and I thought they looked like adrenals, hyperplastic adrenals, and here we see a tumor also. So okay, sorry, here we go. So I started to present with a case. A 35-year-old married woman of Middle East origin. She presented to her GP with multiple miscarriages and difficulty in conceiving. She had menarche at 14 years of age, and thereafter the periods were totally regular. Since 20 years of age, she tried to conceive. At age 25, she had a miscarriage at week 20. And half a year later, she managed to conceive, and 9 months later, she delivered a healthy boy. At age 29, she has another miscarriage at week 15. She was then referred to the private fertility clinic, where they did a vaginal ultrasound who demonstrated the normal ovaries and uterus. They did a hysterosalpingography, which was totally normal. A sperm analysis on her husband was done, and which was normal. The serum testosterone on their method was very high, 6.8, and normal up to 3. And the testosterone sexual hormone binding globulin ratio was very high of 0.17. And she was then referred to the endocrine clinic. And at the endocrine clinic, I saw her, and she presented with mild hirsutis, normal blood pressure. Her BMI was slightly on the low side, and the testosterone on our method was normal, and the testosterone sexual hormone binding globulin ratio was almost normal. But because of she saw me, I thought of non-classic CAH, so I checked the basal serum 17-HOP. It was 48, which is clearly elevated, and if it's above 30, then non-classic CAH is biochemically diagnosed. I followed up with a gene analysis which revealed 2 pathological variants. This one is very common. The V281L is very common in non-classic CAH, so she was diagnosed with that condition. She was commenced on prednisolone 2.5 milligram BD, and 4 months later she was pregnant at 7 weeks. At that time we increased the prednisolone slightly, and a healthy boy was delivered at week 39, and then she went back to 2.5 milligrams of prednisolone once daily. A few years later, she tried to conceive again and was unsuccessful until the prednisolone was increased once more, and a healthy girl was born. And after the pregnancy, once more, the prednisolone was reduced to 2.5 milligram once daily. Her hirsutism totally disappeared when she was on prednisolone, and at age 50 she stopped prednisolone altogether, and there was no sign of cortisol insufficiency, and she has now not been on prednisolone for some years. On one of these visits to the endocrine clinic, her sister joined, and she's a gynecologist. And she had some questions on the diagnosis of her sister. And the sister was 42 years of age, also had difficulty in conceiving, multiple miscarriages, but had managed to deliver 2 healthy children. After the visit with her sister to the endocrine clinic, I sent her for an acetate stimulation test, which clearly showed values consistent with CAH, with non-classic CAH, high 17-HOP after 30 and 60 minutes, and the cortisol levels what showed a slight decrease, so a partial cortisol insufficiency. And the gene analysis was the same as her sister, so she had a non-classic CAH also. But before she came on the appointment for the results, she was pregnant 6 weeks. So I started her on prednisolone just in case, so in order to try to avoid any miscarriages. And she delivered a healthy child sometime later, and thereafter she stopped the prednisolone and she was lost to follow up. However, she represented when she was 50 because she had attended the emergency department with some tummy pain, and they had found bilateral adrenal adenomas, and she was restarted on prednisolone once more. So congenital adrenal hyperplasia is a condition that's mostly due to 21-hydroxylase deficiency. So here in Sweden, it's 99% of all CAH is due to 21-hydroxylase deficiency. You can see elevated androgens and steroid precursors, and then you divide it into classic CAH, where females have atypical genitals, cortisol insufficiency, and are normally found on neonatal screening. And the salt wasting will also have severe aldosterone deficiency. And if you haven't done neonatal screening, if they're not diagnosed within the first weeks of life, they will die in a salt wasting crisis. And then the simple virilizing, which if you don't do neonatal screening and you can't see any atypical genitalia, for example in boys, are usually diagnosed when they're a few years old. And then we got the non-classic CAH, which are normal genitals. However, 10% have a slight increase in the clitoris size. and only have mildly elevated androgens and steroid precursors, and usually presents in childhood up to young adulthood. And the presenting symptoms: premature puberty, acne, hirsutism, menstrual disturbances, infertility, adrenal or testicular tumors. So here is a scheme which you all have seen of the steroid synthesis. So in 21 hydroxylase deficiency, it's a 21 hydroxylase who are deficient. And then you will have high progesterone, which will affect the fertility in females, and 17 HOP, which will be converted through different ways to androgens, androstenedione, testosterone, and DHEAS. And all the other enzymes you see there, 11 beta, 3 beta, HSD, or 17 hydroxylase, can all be deficient in different CAH variant, which are more rare. The gene for CAH, CYP21A2, is in a very complex region, and it has its pseudogene very close by. And when some material comes from pseudogene into the gene for 21 hydroxylase, you might get a variant. And there's also the immune complex very close by, and that has some significance further on, which I will present. There are several pathological variants, and here we can see the normal, the most common one. And the less severe pathological variant, the more cortisol are produced and less androgens, and the in vitro activity increases. So this is a continuum. So the P30L, for example, it's in between simply virilizing and the non-classic. And in a lot of the studies I will show, the P30L has been classified as simply virilizing. So New York City and Einstein, what's in common there? Well, the frequency of non-classic CAH are quite high in New York City. And one of the reasons are the Ashkenazi use. So it has been claimed that 1 in 27 Ashkenazi use have non-classic CAH, and the carrier frequency is 1 in 3. Hispanics is also very common. Croatian, Italians, 1 in 300, and in the general Caucasian population, if you exclude these groups, is around 1 in 1,000. The first study here are the same as the previous slide, but the rest you can see here that the frequency of non-classic CAH is around up to a percentage in certain groups, but otherwise it's usually parts of percents. And in a more recent study, it was checked in the East Coast population of the US. It was claimed that 1 in 200 Caucasian had non-classic CAH. So that would mean it would be very, very common in your practice, but it's not. So how does it look in studies where you looked in the total population? In Sweden, for example, we have a CAH registered, and we have documented all cases of CAH, and we only have 90 cases of non-classic CAH out of 10 millions. In Denmark, they have 142 cases out of 6 million. So very low frequency. And here are the Swedish data, the year of the birth of the patients, and basically most patients, when this study was done in the beginning of 2010, most patients were born in the 1980s or 1990s with non-classic CAH, and that's probably because the younger one hadn't been diagnosed with non-classic yet. And in the study from Denmark, it's more clearly depict that you can see that the increase of diagnosis of non-classic, so it increases every year, probably due to higher awareness of this condition. Some decades ago, there was a study of different centers in different countries. They had 220 non-classic women, and out of these 220, 11% presented when they were younger than 10 years of age or were diagnosed at that, and almost all of them presented with premature pubarche. 80% was diagnosed between 10 and 40 years of age, and the most common symptoms were hirsutis, oligomenorrhea, acne, infertility. So here is another figure showing what's the most common symptoms in different ages. And as you can note here, men are usually diagnosed through family screening and boys through premature pubarche, but also very common in family screening. In adulthood, some patients are also diagnosed as an adrenal incidentaloma. So let's see what's happened here. Yeah. So this patient I saw a few years ago when I worked in Australia. This was a builder who was building a house and fall down a ladder for 5 meters or something like that. And he came in with ambulance to the ED and had a trauma CT. And on the trauma CT, a 5 centimeters adrenal adenoma was seen on the left side. So he was referred after some rehabilitation to the endocrine clinic. Because he was of Greek heritage, I thought, well, could it be a non-classic CAH? He had already a few children and had no acne problems and no fertility problems either. But I did a ACTH stimulation test, which to my surprise showed partial cortisol insufficiency. He only increased serum cortisol to 198, and the 17-HOP was increased up to 460, which is very high. So it looked like he had a congenital adrenal hyperplasia, and the gene analysis showed this P30L variant. So he was diagnosed with non-classic CAH. Unfortunately, he was lost to follow-up. So a few years ago, then we did a meta-analysis of adrenal incidentaloma and how many were later diagnosed with CAH. And if you combine all studies, it's around 6%. But if you look into these who had genetic confirmation, it's less than 1%, 0.8%. And in the cases, the individual cases, you can see if you just look into all, the majority is non-classic CAH, but there's quite a few simply virilizing also, mostly men. But if you look into those who had genetic confirmation, it was equally common with simply virilizing and non-classic CAH. So we looked into our Swedish data, and in Sweden there are only 20 patients with CAH and adrenal tumors, and 15 of these were diagnosed with an adrenal incidentaloma, and then the age was around 58 years of age, and 2 years later they were diagnosed with CAH. Some even had adrenalectomies before the diagnosis. And of these, 80% was non-classic CAH and only 20% was simply virilizing. And let's see, and 2/3 were started on glucocorticoids, and 2 subsequently in the years to come died of an adrenal crisis. which probably was due to being on a prednisolone for a long time, and then you suppress your own adrenals, and maybe they didn't increase their prednisolone doses or hydrocortisone doses during stress. So there wasn't many cases we found when we did this epidemiological research. So then we did a consecutive study of adrenal incidentaloma in regional Sweden. And we did ACTH stimulation test of all adrenal incidentaloma, and 8 were diagnosed with non-classic CAH biochemically. However, when we did the gene analysis, none had non-classic CAH, and 1 was a carrier. And how come? Well, we found that the stimulated 17-HOP is correlated with adrenal size. So that's another reason why, if you have a non-classic CAH, you should check the gene, especially if it's the patient have an adrenal incidentaloma at the same time. So the diagnosis of non-classic CAH can be done on a morning 17-HOP in the follicular phase, if possible, in women. And if you have a level less than 6 nanomole per liter in an adult, it will normally exclude CAH. However, you will miss 11%. So if you have a strong suspicion of non-classic, you should do an ACTH stimulation test. And it's said to be done that check the 17-HOP at 0 and 60 minutes. I usually check at 30 also, but it's not necessary. And if you have a 17-HOP more than 30, it's been said to be non-classic CAH. However, it has been some cases which are just above 30 might just be carriers, or as I showed before, might not even be carriers, and still have a slightly elevated 17-HOP. So it has been suggested to put the limit at 45 nanomole per liter. However, some of my patients have less than 45, so this is a gray zone, and the gray zone are probably up to 60. If you have someone with a 17-HOP of 100, for example, it will be non-classic CAH. So the clinical presentation of PCOS and non-classic are indistinguishable, and a lot of the patients I see in my clinic have been wrongly diagnosed with PCOS before someone thought of non-classic CAH. So non-classic CAH has to be excluded in PCOS. Unfortunately, it's not done regularly. And non-classic in male has been very little reported, and they are usually diagnosed in family screening, as I mentioned previously. And if you look into clinics where they treat severe acne, both non-classic CAH and being a carrier is more common. And some or most non-classic males and females have very discrete symptoms and are not diagnosed until old age or maybe never. So the oldest patient I diagnosed with non-classic CAH were 88 years of age, and she came in as suspicion of ACC, adrenal cortical cancer, and it was an undiagnosed non-classic CAH. But she had already 3 children and hadn't had any issues with her diagnosis or any special symptoms during her life. So she didn't need any treatment. So neonatal screening has been introduced in most Western countries. And classic CAH are normally diagnosed through neonatal screening. However, most non-classic CAH are not found in the neonatal screening. So even if the patient has undergone neonatal screening, they might have non-classic CAH. So why do we diagnose so few patients with non-classic CAH in real life? Well, they have mild symptoms, and especially males are therefore extremely seldom diagnosed. They are usually misdiagnosed, most commonly as PCOS in females. There is an extremely low awareness among health professionals and patients. 17-HOP is a little bit more expensive than other blood tests. And if you do a genetic test, it's very expensive and might not be available in some centers. ACTH stimulation test is not available either in all centers, unfortunately. And probably there are some difference in the prevalence in different ethnicities. So all studies I showed previously were done more or less in high prevalence ethnicities, while in countries like Sweden and Denmark, it's probably a lot lower than 1 in 1,000 or 1 in 200 who has non-classic CAH. So most of our patients are of other ethnicities, are immigrants. So what's the treatment? Well, many patients don't need any treatment if the symptoms are mild or they are asymptomatic. You can do local treatment, which I have shown here, or you can give systematic treatment. And it's important to know that glucocorticoids are not needed for survival. Oral contraceptive pills are very popular in many centers. And the second most popular are glucocorticoids. And you usually want to give them if the female wants to become pregnant, because it lowers the miscarriage rates. And if you have severe symptoms, if you have partial cortisol insufficiency, you're more prone to initiate cortisol. I have one patient, a male patient with non-classic CAH, who was diagnosed after his children were born with the classic CAH, one classic and one non-classic. And when he has pneumonia or influenza, he is pretty sick. So then he take prednisolone, but not when he's not stressed for any reason. Spironolactone has been used in non-classic. I'm not in favor of that because even if you have an non-classic normal, you don't say they have an aldosterone deficiency, but they have an extremely mild one, and giving spironolactone is theoretically not that attractive. However, it does work. And then you can consider other anti-androgens. So here is another schematic table. When should you start treating? Well, basically in children, if you have growth issues, and the more symptoms, the more you're prone to start them on treatment. And the same for adults. So there are fears of long-term side effects when you give supraphysiological glucocorticoid therapy. So you should strive to give the lowest possible dose that normalized the increased adrenal androgens and supplements if there is a partial cortisol insufficiency. Unfortunately, the formulas which we have available cannot imitate the physiological circadian rhythm of cortisol, so usually the patients are overtreated. There are new formulas available, but they are quite expensive and they are not used for they're only used for classic CAH. So there's a balance between glucocorticoid overtreatment and androgen excess. So glucocorticoid treatment can result in increased cardiometabolic complications. On the other side, high androgens in women can result in cardiometabolic complication. In contrast, low testosterone in males can result in increased cardiometabolic complications. So in summary, a normal androgen concentration, as normal as possible, should be aimed for when you have a patient with non-classic CAH. So in CAH in general, in children, you give a dose of hydrocortisone between 10 and 50 milligrams per square meter and day, divided up to 3 doses. And in adults, when you're fully grown, you can give longer actings like prednisolone, 2.5 milligrams to 7.5 milligrams per day, divided into 2 doses, or dexamethasone, which is popular in the US but hardly used in Europe. And when you have a non-classic, you usually are on the lower span of this. So I usually start on 2.5 milligrams of prednisolone if I have a patient with non-classic CAH. So what about the long-term complications? So when we looked in our registries and all our patients with CAH, we saw that the non-classic CAH had increased cardiometabolic complications, especially obesity. Obesity was increased. Diabetes, mainly type 2 diabetes. Stroke was increased. In females, also venous thromboembolism, and thyrotoxicosis and hypothyroidism. And what about mortality? There was only 3 deaths in our patient with non-classic CAH. We compare them with 100 with 300. So we had for each non-classic, we had 100 controls. So the risk of mortality was in fact increased. However, there were very small numbers. And one patient were quite young. And this person died in an adrenal crisis. An adrenal crisis do exist, even though it says in a lot of reviews that if you have non-classic CAH, you can't get an adrenal crisis. Well, it's true if you don't treat them with glucocorticoids, but if you treat them with glucocorticoids, there is a risk. So they need to have stress doses if they have a pneumonia, for example. The other 2 deaths was due to stroke, and they were in quite in the middle age. One was between 50 and 69, and another was between 17 and 99 years of age. In the next study, we looked then into the socioeconomics. So a patient with non-classic tended to be more academically educated. They seem to be in their current employment for between 3 to 77 years of year. The disposable family income were no different compared to controls. They were less on sick leave. However, they were more on disability, pension, and social welfare. And when we looked into the males in more details, they were more married compared to controls. Otherwise, and they were more university educated and more had a PhD. In psychiatric disorders, there was no different compared to controls. The only significant difference was in psychotic disorders, but there was only 1 person with that in the non-classic group. So I think it's a very uncertain finding. And in this study was only 19 males with non-classic. And in females, it was a little bit more, 56 females. And of these, the only significance was in phobic anxiety disorders. What about the male reproductive outcomes? Because infertility might be a way you diagnose the male with non-classic. It's rare, but they might present with a TARTS. In fact, when we looked into the Swedish cohort, there were even a tendency to be more fathers in the non-classic group, or at least you can say they had normal fertility. And when you compare to the other phenotypes, we had more or less half the chance to be a father compared to controls. In females, we can see that CAH in general has less chance to be a mother with a biological child. However, all these are in the salt wasters, while the simple virilizing and the non-classic are totally normal, and the number of biological children in the non-classic are almost normal, so it's around 2. And in the 30 children who were born to 16 non-classic women, the age of first child was normal, 27 years of age, which was more or less the same as in controls. The BMI was almost the same, and the weight gain was almost the same. The only of note, I think, is the gestational diabetes, which was not significant increased, but was in 12.5%. And in the total group, it was significantly increased. So I think all patients, including non-classic with CAH, should be screened for gestational diabetes. 1/3 had a cesarean section, which I'm not sure was necessary. As you might have heard, there has been some literature saying that bi and homosexuality, bisexual orientation is more common in women with CAH. And when we looked into our patient, it was true. However, in the non-classic, we had no patient who were non-heterosexual. So this is only valid for the classic CAH. What about autoimmune disorders? I mentioned before that the gene for CYP21 is in a very immune settings. There's other genes very close by who deals with the complement factors, for example. So there has been some speculations that it's increased risk of autoimmune disorders, and as I showed previously, there is an increased risk of having thyroid disorder, autoimmune thyroiditis, and Graves' disease. And in females, in fact, there were a slight increase in type 1 diabetes. However, it was only 2 individuals. But we couldn't find any other autoimmune disorders who were significantly increased. What about fractures? Well, glucocorticoids could induce fractures, and when we looked into the classic CAH, they had more fractures compared to controls, but that was not seen in non-classic CAH. So they had similar rates compared to controls. And we recently looked into injuries and accidents. And the classic CAH, especially the females, has an increased risk of having injuries and accidents, which was not seen significantly in the non-classic. However, for some unclear reason, head injuries was slightly increased, which we don't have any explanation of. So what about follow-up? If you have a patient, how often should you follow them up? Well, if you have a child, every 3 to 12 months, depending on symptoms. In adults, usually annually, if you put them on treatment, especially glucocorticoids. Otherwise, every 2 to 3 years, I think it's reasonable to check them. And you check in children the growth velocities, but in both children and adults, weight, blood pressure, 17-HOP. We prefer doing 24-hour profile using dried blood spots. It's normally not available in most places, but we prefer that. Bone age in children, androstenedione, testosterone, sexual hormone binding globulin, and in adults, we also check fasting glucose or HbA1c, bone mineral density if they're on glucocorticoids every 3 to 5 years, and a testicular ultrasound every 5 years. There has been claimed previously that non-classic patients don't have TARTs, but it has been published. We have published a few papers of that and others also. So here's just an example of 17 HOP diurnal curves. Most of these patients have classic. And by doing that, you can see you can have a high 17 HOP in the morning, but then if it drops down during the day, well, then it's good control. So a morning 17 HOP is quite unreliable to use to direct your treatment. So in summary of the clinical management, I think every patient with CAH should have a gene analysis done, both to confirm the diagnosis, and that's especially important in non-classic, but also for classifying the genotype. Is it this P30L, which is a more severe type of the non-classic, or is it the more common B21L? And the hydrocortisone or prednisolone are the most favored glucocorticoids. In children, you should not use prednisolone because it might inhibit growth. And the doses, it's usually on the low side, so 2.5 milligrams is usually enough. Sometimes you have to increase during pregnancy, or you usually increase during pregnancy. And we talked about this, oral contraceptive pills are very effective, and many do not require any treatment at all. So in conclusion, non-classic CAH is more common than previously thought. Non-classic is not fatal if not diagnosed. Non-classic can affect fertility, but it can also affect other things. So I think it's important to diagnose these cases. And managing non-classic can be challenging, and most endocrinologists has quite little experience. And knowledge about the other non-classic CAH variants, for example, non-classic 11 beta hydroxylase, is extremely limited worldwide. So this was when I came to my clinics when I worked in Australia. We found a snake. But fortunately, at the Karolinska, we don't have snakes. And here you have my email. So I'm happy if you have some questions about non-classic in the future, you can send me an email if you have a patient which you want to discuss. I'm happy to take any questions.
Thank you very much, Henrik, for this comprehensive and excellent lecture. Do we have any questions from the audience? I don't see anything in the chat, but I will check here. You can also ask the questions directly if you raise your hand, and Amy will let you in.
So I usually talk about this non-classic whenever I have a new doctor coming here. So we have a lot of new doctors coming from other hospitals, staying here a few months to do some training. And it usually takes a year or two, and then they will give me a call or send me an email, and then they will have found a non-classic. So I think the awareness is very important, because if you don't know about the condition, you will never find this kind of patients.
That's true.
There is one small question. Perhaps you're not seeing it in the chat there.
No, I'm not seeing it in the chat, actually. Yeah, well, is adrenal radiology usually normal in most, is the question.
There is no study where you've done CT scan on all. However, I can't really answer that because we don't do a CT scan regularly, and I don't think you need to do that either. But some patients, I mean, I have quite a few who has been found as an adrenal incidentaloma, but then they were found, and then it was turned out to to have non-classic CAH. I'm not sure. Yeah, I presented one of the non-classic CAH. This sister, she had some tummy pain and then had bilateral adrenal incidentalloma or adrenal tumors. I don't know, and I'm not sure we really need to figure that out as long as the treatment goes well. But basically in the classic CAH, I think if you have difficulty in controlling and the patient really takes the glucocorticoids, well, it can be valid to do a CT scan of the adrenals, and if they have huge adrenal, like 20 centimeters away of size, then you might need a bilateral adrenalectomies, but that's very rare cases. It has been shown that the myelolipoma is more common in CAH. So if you find a patient with all the patients at the Karolinska with a myelolipoma more than 20 centimeters of size, all have had CAH, but they have all been classic. None have been non-classic.
We have a few more questions for you, Henrik, and the second one is how to manage non-classic CAH in pregnancy.
In pregnancy, so if they are not on glucocorticoid, I start them on a glucocorticoid because we think we reduce there was one study who showed you reduce the frequency of miscarriages if you started them on glucocorticoids. So I start them on that. If they want to conceive, I tell them about this, and more or less everyone want to start it. So this I have another gynecologist with this disorder, and she is very afraid of glucocorticoids, but when she wanted to become pregnant, of course she doesn't want to have miscarriage, so she started just before she conceived, and then normally you can increase in the third trimester, and then after delivery you can go back to the normal dose than before, or just stop it. I usually don't stop just after delivery because there's a lot of things to do then, but after a couple of months. So 2.5 milligrams BD, for example, is a very common dose in pregnancy, or sometimes I increase that to 3.75 milligrams in the morning and 2.5 in the evening. Checking 17-HOP and the androgens, I do that, but they all go up very high. That's physiological, so you can't really monitor on that. So you have to look on clinical parameters.
We have a colleague from Greece also asking, first, thank you for the great lecture. And when would you consider changing to COX in adolescent females? I think, what do you mean by COCS? Like, this colleague would like to explain. I don't know what COCS means in this case.
Or is it?
When would you consider changing to?
Changing to
contraceptives, or is
it? So the contraceptives, well, if there's just mild symptoms, you can start on a oral contraceptives, and that usually would manage the symptoms. But if they want to become pregnant, then I switch to the glucocorticoids and maybe switch back to an oral contraceptives afterwards. Having oral contraceptives after 40 years of age, it's a bit, maybe you shouldn't. But and a lot of patients, they don't have any treatment after 50 years of age. No glucocorticoids or any anti-androgens either.
Okay. We have another question. When it's more proper to make preconception carrier screening tests and neonatal screenings, having in mind the dropping down prices of DNA tests?
Yeah. So should you check the partner if you have a patient with non-classic? I don't.
So the question here is using preconception carrier screening instead of neonatal screening, which I think, I mean, it's two different things.
Okay. Preconceptional, well, then you should check the partner if they are a carrier or not. I don't do that regularly because I think this is a condition who has pretty good quality of life, and should you really do, for example, abortion if you know your child have CAH, it's an ethical consideration, and or should you do some PGD or something like that? It's quite complicated, so I don't recommend that. Of course, if you have two cousins who are married and one has non-classic, then it's maybe more valid, but I normally don't do that. And screening, well, all children should do the neonatal screening program, and and if the child after a while starting to having some symptoms that might be considered could be non-classic, well, then they should be referred liberally to a pediatric endocrinologist. But I don't think we should follow up all children or gene test them or anything like that if they don't have any symptoms or they're not diagnosed with non-classic CAH.
Thank you, Henrik. I think that was the last questions. If you don't have anything else, Amy, no, in the chat?
No, that's it. And there's no hands raised either.
So thank you very much. And I think we will close this session for today. Thank you all for listening. Thank you, Henrik.
Thank you.
Thank you so much, Professor Fallhammer and MTG1 for organizing this event. And if you want to know more about the Endo-ERN webinars, please ensure that you subscribe to our newsletter on our website. The recording will go out in 48 hours. Enjoy your evening.
Thank you.